Okay, good afternoon, everyone. Assalamualaikum. Can everyone hear me from the chat? Just say yes in the chat box if you can hear me. Okay, can we start? All right, okay. Thank you, Siti. So we shall start now. I think we already have a good number of participants. Good evening again, everyone. Welcome to the College of Physicians Malaysia and Malaysian Osteoporosis Society special webinar on osteoporosis. I believe today we are honored to have Associate Professor Dr. Jayakanta Ratnasingam with us to talk about osteoporosis. Before we start, I shall brief everyone background of Associate Professor Dr. Jayakanta. His undergraduate degree from National University of Malaysia. Advanced endocrinology with the Ministry of Health Malaysia and had undergone a fellowship in endocrinology at the Princess Alexandra Hospital, Brisbane, in Australia. He manages patients with type 2 and type 1 diabetes, osteoporosis, pituitary, thyroid, gonadal, and adrenal disorders. So currently, Associate Prof. Dr. Jaya is a consultant endocrinologist and the head of endocrinology unit at the University of Malaya Medical Center. Without further ado, I would like to invite Associate Prof. Dr. Jaya to give a talk on a systematic treatment approach to managing osteoporosis effectively. Associate Prof. Dr. Jaya, the floor is yours.
Thank you very much, Prof. Hakima, and good afternoon, everyone. It's really a privilege for me to present today because I think this is I'm doing the final of the 3 webinars. And I suppose my topic I've probably been given the heaviest task to actually look at systematic approach in terms of managing osteoporosis effectively. So I think to take you through this, I will do some case illustrations and do submit your questions, ladies and gentlemen, because we will, Prof. Hakima and I will have time to take the questions in the last 15 minutes or so. So just a bit of outline in terms of what I'm going to be presenting this afternoon over the next 35 minutes or so is a structured approach to managing osteoporosis. Basically, I want to cover things like we need to know when to start active anti-osteoporosis therapy. That's number 1. Making the right choice of therapy for the right patient. I think tailoring it to the right patient, that's also important. Knowing when to start, when to stop also is important, because if you start something, you also need to know whether you need to stop. And this, I know you know that I'm talking about bisphosphonate therapies. Also knowing when to switch, when is there treatment failure, and when do we need to switch therapy, that's also important. Dealing with the high and very high risk individuals. And this is a topic, or this is a subject that has become more and more of interest nowadays. If you go to osteoporosis meetings around the world, or even in our country, there's a lot of talk about using anabolic agents for the very high-risk individuals to prevent fractures, and I'll touch about that. In the interest of time, I'm not going to talk about calcium, vitamin D, non-pharmacological aspects of management, because there's no time. But that I'm not saying that it's not important, although I don't talk about it. These are also very, very important. These are the building blocks of the bone, and these are also important to strengthen the bone, but I'm going to focus on active anti-osteoporosis therapy. So the first question you have to ask yourself is, why should I even bother? I mean, I congratulate all of you. There are almost 30 of you here in this webinar because you're interested in osteoporosis, because you know the consequence of a hip fracture. 1 in 3 after a hip fracture can't walk unassisted 2 years after a fracture. 1 in 4 will actually end up in a nursing home. And in fact, 25% of them will die as a consequence of hip fracture in 12 months. So you need to do something to prevent these hip fractures. Are we doing enough? Although this data is quite old, maybe about 10 years old, but this is what we have in terms of a large database of 1,000 over patients who have been audited across Asia. These are hip fracture patients, okay? Patients who come to the wards with hip fracture, you know these are serious osteoporotic fractures, but even in those individuals, only 50% were informed that they had osteoporosis, and sadly, only 1/3 of them had BMD measurements, and only 1/3 of them received anti-osteoporotic treatment within 6 months post-discharge. So we are really missing, despite them fracturing. We are all talking about osteoporosis over the last 3 weeks, but yet the situation is still that we are missing treatment. Many women, postmenopausal women, and elderly men and women are missing out in terms of osteoporosis treatment. So my first case that I'm going to illustrate to you is Puan Amina. She's 82 years old. She's been having back pain for a long time. She's menopausal. She's never took any hormone replacement. There was nothing to suggest that she was on any traditional medicines or falls or fractures in the past. And she comes to the ortho clinic and a BMD was actually ordered. So you can see this, her bone density. You can see that there are a lot of osteophytes there. There are degenerative changes. And so that's why you have very varying T-scores. If you can see here, the T-scores can vary from positive 0.2 to negative 3.5. That's because there's a lot of osteophytes, degeneration, and sclerosis. So, of course, you want to look into the hip as well. And this is the same patient's hip, Puan Amina's hip. And you can see that her hip is clearly in osteoporotic range, minus 3.8. And then you ask yourself, okay, this 82-year-old lady, what treatment should you start? Of course, you need to start treatment. I hope you all know that. And then you have to ask yourself, which agent would you want to choose for her? So just to recap, this is very basic in terms of NOF guideline, National Osteoporosis Foundation guidelines, very old, but it still holds true because this is really the basis in which we decide to treat patients with active anti-osteoporosis treatment or not. So when you see someone who is postmenopausal or men above the age of 50, first of all, you must always exclude secondary causes. And once you have excluded secondary causes, if there's a clinical diagnosis of hip or spine fracture or major osteoporotic, any kind of major osteoporotic fracture, then that patient would be deemed to have osteoporosis. Regardless of bone density, you would want to start treatment. Of course, the other aspect in someone who had no fracture before is to look at the bone density, and if the T-score is worse than minus 2.5 at the spine or hip, then of course you want to start on treatment. If you have someone on the right side, a T-score between minus 1 to minus 2.5, then you can do what is called the FRAX, the 10-year fracture risk assessment. And generally around the world, although now in Malaysia, we also have our own intervention thresholds, fixed intervention thresholds that we, managed to look at. But around the world, most people will adopt this, which is the 3%. If your 10-year fracture risk is more than 3% at the hip and more than 20% for major osteoporotic fracture, then you qualify for active anti-osteoporosis treatment. So active treatment here means starting them on a bisphosphonate, starting them on denosumab, starting them on an anabolic agent. So these are the criteria. So if you have fracture, you should start definitely fragility fracture. If your T-scores are below minus 2.5, you should consider starting. If your T-score is still all right within osteopenia, but if your FRAX is not good, then you also should start treatment. So in terms of treatment, you can divide them into, of course, anti-osteoporotic agents and bone-forming agents, okay? So on your left are bone-forming agents, and on your right are anti-osteoporotic, anti-resorptive agents. So anti-resorptive agents is what we commonly use, such as the bisphosphonates. Of course, you have oral forms as well as IV form. The oral form, alendronate, brasidronate, ibandronate, IV zoledronate acid, which you use which you use yearly. And then, of course, you also have SERMs, which is selective estrogen receptor modulators, such as raloxifene. And you also have denosumab, which is probably the strongest among all the anti-resorptives. On your left, you have the bone-forming agent, which is basically parathyroid hormone, teriparatide. And also now in Malaysia, we have this new agent, which is actually a bit of a combination between bone-forming as well as anti-resorptive is a dual agent called romosozumab, which is an anti-sclerostin antibody. So these are the agents that we have in Malaysia, and let's look at the data of these agents. So this is just a forest plot that I've put for you, and you can see the line of unity there, number 1.0, and in terms of relative risk reduction, in terms of vertebral fracture rates, and you can see how potent these agents are and what their landmark trials are. So you have alendronate there, the FIT1, FIT2, the residronate, the VERT trials, ibandronate bone, zolendronate horizon, raloxifene the MOR trial, tibolone lift, SOTI trial with strontium, okay, of course, the parathyroid trial and the freedom trial with denosumab. So you can see here that the most potent of the agents, which reduce the risk about more than 50%, about 60% or so, is zoledronic acid as well as denosumab. A little bit more, less than that is things like alendronate and residronate. And of course, the weaker agents are like raloxifene and tibolone, maybe about 30-40% in terms of risk reduction of vertebral fracture. Non-vertebral is not as powerful as what you see with vertebral here. You can see here across the board, most of the agent about 20-40% risk reduction in terms of non-vertebral fracture. And in hip fracture, you can see, there's a bit of mixed data here. It's been reported with alendronate, residronate, and denosumab, and as well as zolendronate, which is quite powerful. You can see denosumab and zolendronate, okay, almost about 40% risk reduction. Equally powerful with alendronate as well, but it's not reported with ibandronate, not reported with tibolone, also not reported with teriparatide. And with raloxifene, you don't have that data, that hip fracture efficacy data. That's why we don't recommend using raloxifene. You can see that it's already crossed the line of unity, so we don't recommend using that for postmenopausal osteoporosis, where the hip is the site that you want to target. If there's osteoporosis in the hip, and the patient is elderly, you think the hip frax is actually high, you wouldn't want to use raloxifene because it basically only has spine data. So to summarize all of that, what do you do? Because of the interest of time, I have to summarize. And most of you, I think, are primary care as well as general internal medicine physicians. So I think I want to, look into 5 different aspects. What are the factors that you look at before you decide therapy? Number 1, age. Number 2, site of fracture. Number 3, renal function. Number 4, compliance and adherence. Number 5, presence of ASCVD. So if the site is vertebral, basically semua boleh pakai. You can use raloxifene, bisphosphonate, denosumab, teriparatide, romosozumab. If the site is actually hip or non-vertebral, you can use the rest, but you don't use raloxifene because the data does not support it, like I showed you just now. If you have someone with a GFR below 35, the only 2 agents that you can use at a reduced GFR is denosumab and romosozumab. Okay, if you have, in terms of age, of course, if you can see here, basically you can use the anabolic agents anytime as second line. The younger, immediate postmenopausal woman you can use raloxifene. A little bit older, you want to look at bisphosphonates and denosumab. If there's presence of ASCVD, then of course, I wouldn't recommend the use of romosozumab, although the label for Malaysia will say you are only contraindicated if you have an established cardiovascular event or stroke event that happened in the last 1 year. I probably would be on the side of caution and not to use it in people who already have established ASCVD. So this is a different patient. This is the second patient. Let's look at her. She's here. She's a 79-year-old lady with Colles fracture, and she was started on alendronate. And if you can see here, this is her BMD from 2018 to 2023. I will save you the trouble of calculating the least significant change, or showing you the least significant change and calculating the changes. But I just want to show you here that this is the BMD, the density change in the lumbar spine and the neck of femur from 2018 to 2023. So she's 79 years old. She's had a fracture before. So it has gone up, okay, showing that the alendronate is working, okay, 0.063 in the spine and 0.050 in the neck of femur, and the least significant change are given there as well. So these are improvements that are more than the least significant change, indicating that these agents work. So you have Mrs. Chan here, who has a neck of femur T-score that is minus 3.1. Okay, that is her latest T-score. She has had good improvement with alendronate in the last 5 years. Okay, you can see that. but she has concerns about taking alendronate for a long time. I mean, I'm trying to address the common scenarios that you will get in your clinic. So what do you say? And how many of you, okay, you can think to yourself, how many of you would stop treatment or how many of you would continue? So the reason why people want to consider discontinuing bisphosphonates or even going on drug holidays is because of adverse events that have been reported before. The two most worst of the adverse events are, of course, atypical femoral fracture as well as osteonecrosis of the jaw. But I just want to put it to you in simplistic terms that we know the benefit of these agents. And we know that these risk factors or these adverse events that happen, AFF as well as ONJ, happen, only with increased exposure, increased duration of time. So if you can see here, if you look at the table in orange on top, the AFF risk per 100,000 patient is about 2, okay, per 100,000. If you use it less than 2 years, and it goes up. If you use more than 10 years, it goes up exponentially to 100 per 100,000. Okay, ONJ is even more rare. Okay, even if you use it more than 4 years, the risk is 0.21%. So these are actually very small risks if you use it for short duration of time. So putting things into perspective, this is important for us to understand so that we can explain to patients, because when they read about alendronate, they might think, doctor, why are you giving me this? This is going to make my thigh fracture. I'm going to fracture my thigh bone, or my tooth all going to fall off. Dentists always have this concern. They send patients back to you. So you need to put it in perspective. Okay, if a 70-year-old woman with a femoral neck T-score of -3, which is what Mrs. Chan has, and if she's untreated, her 10-year osteoporotic fracture risk is 25%. If she's treated, you halve that to 12.5%. And you can see I've compared the ONJ and AFF risk, which is below 1% there. You can see it's very low. In fact, a fatal MVA, 10-year probability of that woman ending up with a fatal MVA is going to be higher than developing ONJ or OFF. So that's why if you look at this NOGG guidelines, they will tell you what to do, okay? These are people who are on bisphosphonate, postmenopausal women who are on bisphosphonate. At 3 to 5 years, of course, you need to re-evaluate whether you need to continue. So if there's recurrent fractures or prevalent vertebral fracture, patient's age is more than 75, on a glucocorticoid dose of more than 7.5 milligram, of course, you check for adherence, exclude secondary causes, and then you would want to continue treatment. If there's no fracture and you repeat the fracs as well as the BMD, okay? So if your fracs and BMD, if you're below the intervention thresholds, and if your hip BMD is more than -2.5, that means better than -2.5, you can consider a drug holiday. And after 1.5 years, 2 to 3 years, you need to reevaluate by repeating the fracs as well as the BMD. On the other hand, if you're like Mrs. Chan, if your T-score is worse than -2.5, -3, okay, and if your NOGG intervention threshold is above, it's surpassed, then you of course need to again check for adherence, reevaluate, and continue. So if if your risk is high, your T-score is no good, then you need to continue on the alendronate, and you can go on maximum probably about 8 to 10 years, okay? Okay, if you're looking, that's for oral bisphosphonate, but if you're looking at zoledronic acid, okay, of course, it's much lower than that. Okay, at 3 years, of course, you have to already evaluate for both oral as well as parenteral bisphosphonates. So this is another patient. So let's look at this patient. She had a fall in the bathroom about a year ago. She was asymptomatic. And you can see here, this is what her bone density looks like. Okay, so I'll just give you the T-scores there. If you're really sharp, you would have spotted what the problem is there. And of course, what you'll order when you see that kind of bone density in Mrs. Davy is actually to do a spine X-ray. So her T-scores are no good. Actually, it's worsening. Okay, while she's on alendronate, it's worsening from -3.2 to -3.4, and that is worse than the LSC. And she's already sustained a fracture. Okay, so worsening BMD and fracture. These two things are happening in this lady, Mrs. Davy, who has been on alendronate for some time. So you ask yourself, would you change treatment or will you continue? If so, what you want to change to? Okay, so if you have, oops. Sorry. So how do you define, sorry. Sorry. So how do you define treatment failure? So treatment failure basically means if you have two or more incident fractures, if you have one incident fragility fracture associated with decrease in BMD, which is more than the least significant change or no change in the bone turnover markers, or a decrease in BMD, which is more than the least significant change associated with no change in the bone turnover markers. So these are sort of criteria that's given in this paper to define treatment failure in people who are on anti-osteoporotic therapy, okay? So if you have actually having one fracture, is not purely a treatment failure, but if you have two or more fractures, then they define that as treatment failure. Or if you have fracture with decrease in BMD, like our patient, okay, Mrs. Devi, then you of course need to think of switching treatment. And one of the things that you can do is, of course, to switch to a more potent anti-resorptive, such as denosumab in this case. So I'm showing you denosumab data here from the Freedom trial, looking at the, this again, this is placebo-controlled. In gray is placebo, and in green is Prolia or denosumab. And you can see here the rates of new vertebral fracture, non-vertebral fractures, and hip fractures all come down quite significantly, okay, with use of denosumab or Prolia. And this is actually comparing bone density data itself, okay, from the trial, looking at bone density with patients who are on alendronate versus denosumab in orange. You can see that alendronate in orange and denosumab in white, and you can see that the denosumab increase in BMD is way more compared, although it looks like 1%, 0.6%, but mind you, that's a lot in terms of bone density measurements. And that has increased, that shows that denosumab is more powerful as an agent compared to alendronate. So the other thing is kidney function here. So they have also studied denosumab across the board, CKD stage 1, 2, 3, and 4 here. You can see that the effects are sustained, okay, in patients with impaired kidney function. So you also can be quite confident to use it in patients who have CKD stage 2 to 4, because it's still powerful in terms of reducing the rates of fractures here, new vertebral fractures and non-vertebral fractures that I show you in the bar graph here. So that's about, in terms of vertebral fracture, almost about 60%. You can see here, non-vertebral fracture, about 20% relative risk reduction. So although I've said so much about alendronate, now denosumab, we must remind ourselves that denosumab is an agent that you cannot basically stop once you start. And there's data for that, because here I'm showing you BMD change from baseline, people who are on denosumab. Okay, when they go on off treatment, you can see a significant drop in terms of the bone density. And this also translates to fractures. Okay, because this is actually looking at all subjects who are on treatment and off treatment. You can see that the off treatment group, the rates of vertebral fracture goes up quite a lot. Okay, from 1.2% if they're on treatment to 7.1% if they're off treatment with denosumab. And it's worse in people who have prior fragility fracture. So denosumab, if you're on denosumab, it's about 1.9 per 100 subject per year, and it goes up to 12 per 100 subject per year in terms of vertebral fracture. So this goes to say that basically there's no, just to remind all of you that there's no drug holiday when you're on Prolia or denosumab, okay, because there's a rebound increase in terms of vertebral fracture rates if you discontinue. So if you want to change, you basically can't discontinue patients who are on denosumab, because you know that there'll be a very rapid drop in bone density, then that's associated with an increased vertebral fracture rate. So basically you need to transition over to something else, either another anti-resorptive or use an anabolic agent. So this is the final case that I'm going to illustrate. This is Mrs. Lee, who is a 74-year-old. She has postmenopausal osteoporosis, a typical University Malaya Medical Center patient who has had osteoporosis for so long. Okay, she had Colles fracture in 2015. She on alendronate for 6 days, denosumab for 6 years, 2009 to 2015. She was on denosumab from 2015 to 2022, and she had a fall. And she fell, she fractured L2. That was early this year, and possible fracture at L4 as well. And you do the other screening, such as vitamin D. Okay, you want it to be more than 75 nanomoles. She's at 78, so that's quite okay. Kidney function is all right. Her calcium is okay. There's no other secondary cause. She's not on any steroid. She's compliant to medication. And you ask yourself, what is her future fracture risk? So this is a 74-year-old, had Colles in the past, already been exposed to other anti-resorptives, and now having a L2 fracture, possible even an L4 fracture. And how would you approach her management? So these are very high risk individuals in which we need to focus the next couple of minutes on. Okay, so this is actually the latest guidelines, Professor Kaney's guidelines, maybe about 2 to 3, it's actually not that new, it's maybe about 3 to 4 years old already, which looks at this heat map or this traffic light color coding in terms of risk. So you can see here in terms of initial assessment, of course, you do the clinical fracture, you use clinical risk factors to calculate fracs, and of course, you can put patients in different, so the orange area there is basically the intermediate zone, and the line that goes in the middle of the orange area is basically sort of the intervention threshold. So of course you have the red zone, the low risk green zone, and the in-between zone. So basically if you fall in the green zone in terms of your fracs, okay, this is basically looking at fracture probability with time. And if you fall in the green zone, basically you are low risk and you don't really need a bone density. If you fall in the red zone, you're already very high risk. And basically you need to move on to treatment even if you don't have bone density. But if you're in the orange zone, of course, that's where you need to recalculate the fracs using a bone density. So the initial fracs is calculated without bone density. And then if you fall in the intermediate orange area, then you would want to calculate a bone density and decide the fracs, decide the fracs risk. So basically, you know, most of the guidelines nowadays will tell you patients are at very high risk if they had a fracture within the prior 2 years. I'll show you another table that details this, as well as if they fall into high risk if they have any prior fragility fracture. So the recent fracture is actually a higher risk compared to someone who had fracture much earlier on. And that's been proven again and again in different studies to show that, you know, women, postmenopausal women who had fracture in the last 2 years, their risk of having a new fracture is the highest compared to someone who had fracture like 5 or 6 years earlier. So based on the risk categorization, okay, that you fall into, whether you're low risk, high risk, or very high risk, so you would actually determine the type of treatment or how your treatment approaches and goals are. So in all of them, of course, you want to optimize calcium and vitamin D status. You want to incorporate non-pharmacological, appropriate exercise, fall prevention. But if you're someone in low risk, in green, you probably can consider things like menopausal hormone replacement therapy or SERM. So these are the low risk. If you're someone in high risk, or which is the orange zone, okay, you want to consider anti-resorptives like oral bisphosphonates or other inhibitors of bone resorption. You can use denosumab or even zoledronic acid. If you are dealing with someone with very high risk, then you know in the red zone, then you want to consider the use of anabolic agents earlier on compared to using it later on. So these are the very high risk individuals like Mrs. Lee. So this is the IOF ESCO, which I've been trying to describe to you in the last 2 or 3 minutes, okay, and in terms of what the details are in terms of risk categorization. So you can see here what low risk is, what high risk is, and what very high risk is. So basically, low risk means you are below the fracs intervention threshold, no fracture, and your T-score is more than -2.5. High risk means you are above the low risk fracs intervention threshold and or you have prior fragility fracture, okay? So basically you are in the orange zone. And if you're above the high risk fracs intervention threshold and or you have a recent fracture in the last 2 years, then you will fall into the very high risk category. And you can see here the differences in terms of treatment. So you can see it's a continuum. In one end of the spectrum, you have menopausal hormone replacement therapy, SERMs, okay, a lower, less intense kind of treatment. And on the other end, you have the very high intense one where you want to go into anabolic agents such as teriparatide or romosozumab followed by anti-resorptive agents. So in the next couple of minutes before I wrap up, I'm just going to talk to you a little bit about romosozumab. We have had experience using it in the last 1.5 years or so in Malaysia. And it's it's the most powerful agent in terms of anti-osteoporotic efficacy. So it's basically an anti-sclerostin antibody, and basically by inhibiting sclerostin, it will reduce bone resorption and it will increase bone formation. That's what it does. And the studies are very nicely named. You have the FRAME study, which I show you here, is basically Evinity or romosozumab, which is given 210 milligram subcutaneous once a month, okay? So denosumab is given subcutaneous 6 monthly, Evenity is given subcutaneously once a month for 12 months. So, and then after that, they had the open label as well as the extension phase. And you can see here, if you look at the first 12 months on your far left, you can see a 73% relative risk reduction. So new vertebral fractures. This has never been seen with any other agent before. Okay, up to 24 months later, you know, this is the open label phase where the Evenity group goes on to Prolia, as well as the placebo group also goes on to Prolia. There's still the benefit of the Evenity is seen. And there's still, at 24 months, those who were on Evenity or romosozumab had a 75% relative risk reduction. And even up to 36 months, you still see that benefit in terms of new vertebral fracture. So these are all the key fracture outcomes where whatever you like, you can take a pick: non-vertebral, clinical, major osteoporotic, hip, you know, you can see that across the board, okay, those who were started on Evenity first and then went on to Prolia had a much lower risk of fracturing compared to those who were on placebo, then went on to Prolia. So that anabolic effect is very, very strong. You see it in the first 12 months. You see it even lingering 24 and 36 months. So this is similar data again, but this is looking at new vertebral and non-vertebral fractures, looking at the ARCH trial, which is another trial. So this ARCH trial actually compared against alendronate. So they had an active comparator here in the first 12 months. You can see a 37% relative risk reduction. And those who were later on went on from from Evenity to alendronate, they had that sustained relative risk reduction in terms of fracture rates for new vertebral, non-vertebral, as well as hip fractures that you can see, okay, at prolonged duration, such as 24 months and 33 months later on. So this is the ARCH trial, which compares high-risk individuals between Evenity and alendronate. So this is the Evenity versus teriparatide study, which is the structure study that looks at BMD. So this study doesn't look at fracture outcomes, but this is comparing teriparatide, which is the strongest anabolic agent that we have had until Evenity came about. And you can see here that Evenity, okay, lumbar spine and femoral neck, Evenity's effect on bone density is more greater, okay, about 3 to 4% greater compared to teriparatide. So if you line them all up, the pivotal trials, if you ask me, Jaya, which are the agents that are the most powerful, you can line them all up like this, from alendronate to teriparatide, to Prolia, to Evenity. You can see here in terms of BMD gain, change from baseline, you can see that romosozumab or Evenity has the highest BMD gain, followed by denosumab. Okay, these are in terms of BMD gain. But of course, BMD gain is different from fracture outcomes. You might argue that, but this is sort of a surrogate marker in looking at efficacy of an agent. So the only thing that has come up as a red signal that we must all know when we want to use romosozumab or Evenity is in terms of the MACE endpoint. So there was an increased risk of MACE in the romosozumab arm, and this was seen actually in the ARCH trial. So that's why there's caution in some countries. If you have established cardiovascular disease, you don't use it. In Malaysia, the product insert will say if in the last 12 months, patient had stroke, myocardial infarction, they cannot use romosozumab. So to argue that, this is Felicia Cosman's favorite slide, to argue, to look at, the different trials, the arch frame structure, and the extension trials, you can see here that in terms of change in lumbar spine and hip BMD, okay, on your left is lumbar, and on your right is hip BMD, you can see here, those who were actually given, okay, romosozumab prior to alendronate or romosozumab prior to denosumab, which are the green bars, their BMD gain is much better compared to those who were given the other way around, okay? Those who were given romosozumab after alendronate or romosozumab after denosumab. So you actually do best if you start with an anabolic agent first in terms of BMD gain compared to starting with the anti-resorptive and then going to an anabolic. That's why in very high-risk individuals, nowadays, most guidelines will recommend to use a anabolic agent, either romosozumab or teriparatide first, then move on to a anti-resorptive like alendronate or denosumab. So ladies and gentlemen, I showed you, Mrs. Lee, Mrs. Chan, Puan Amina, Puan Devi. I hope it covered different sort of aspects. The first patient was an elderly patient who was treatment naive and you decided on what to treat her with. And then, of course, the second patient was someone who we discussed drug holidays as well as adverse effects, putting bisphosphonates in perspective. The third patient was someone who was failing while on bisphosphonates, and you want to step up in terms of either going to denosumab. And the final patient was someone with very high risk, which I talked about, anabolic agents. So to summarize all of that, I've done this table here, okay, including romosozumab. Okay, I hope, this table will be useful for you as a guide. Okay, so I put raloxifene right at the end. Okay, this is in Interbicos on the left, and I put romosozumab right at the end on the right, because in terms of efficacy, this is how you are going. Okay, so of course, raloxifene, you use it in the younger, denosumab, alendronate, the bisphosphonates, zoledronic acid, okay, anywhere above the age of 65 should be fine. Teriparatide and romosozumab basically is used as second line in most countries, including ours and around the world. It's used as second line for very high risk individuals because these are anabolic agents. Renal function basically needs to be good for alendronate and zoledronic acid, but it can be poor in denosumab and romosozumab patients less than 35. If you look at vertebral fracture benefit, all of it have. Okay, for hip, raloxifene doesn't have, but the rest have. And I put more plus means more powerful. Okay, like teriparatide, romosozumab, denosumab are more powerful compared to some of the older anti-osteoporotic agents. The mode of administration also you need to consider, because some people, they don't want to inject daily at home like teriparatide. Some people prefer to come every month for romosozumab, but some people don't want to come. Some people want to inject at home. Some people, 6 months is the best they can do. And others like oral, and others like IV in the hospital once a year, like zoledronic. So you need to tailor that to your patient as well. Duration of use, basically I've showed here, raloxifene, probably maximum 5 years. Alendronate, oral alendronate, 3 to 5 years, you must reevaluate whether the patient should go on a drug holiday. I showed you the NOGG guidelines, or whether you think the patient should continue still until about 8 years. By then, that's max and you want to stop. Okay, zoledronic acid IV at 3 years, you need to reconsider. Denosumab, there's data until 10 years, but of course, basically you can't stop. You go on because if you stop, you will lose, or either that or you need to transition to something else. Teriparatide is given for 18 months up to 2 years in some very high-risk individuals, and romosozumab is 1 year. And I also put the dollar sign. I should put RM sign, but basically, which are more expensive. The anabolics are more expensive compared to the anti-resorptives, and some of the anti-resorptives, the oral ones, of course, they are generics like alendronate. So, of course, it's much cheaper compared to the others. So, ladies and gentlemen, Prof. Hakima, I think I will stop here, and just to summarize, so that we can discuss a bit of Q&A. I think I tried to put, in the last 40 minutes or so, how we can actually approach a patient in a structured manner. Basically, the indications to treat will depend on FRAX, what your BMD data is, and presence of previous fracture. Things that you'll consider, I'm sure you all do this in your clinic, but I'm just putting it out on the slide for you. Age of the patient, you consider, right, to decide on what treatment you want to give. Site of fracture, the patient preference and affordability, these are also important. Renal function, some patients like to inject, others don't like. Some people like it 6 monthly, some people like it yearly, some people want it monthly. And although I've spoken a lot about different agents, I showed you some data about denosumab, some data about romosozumab. I've showed you the forest plot looking at the older agents like bisphosphonates, as well as zoledronic acid. But you also must not forget the non-pharmacological aspects, fall prevention. I think Prof. Hakima will definitely agree with me on that, especially in the elderly, frail individuals, because fall prevention is equally, if not more, important than all these active agents that you're giving that cost money. So I always, in my consult, I try not to forget this, to tell patients, simple things to prevent fall might be equally as beneficial, maybe even more efficacious than, all the agents that I spoke about in the last 45 minutes. So I think, Prof. Hakima, I will stop here so that we can open for some Q&A from the audience.
Thank you, Prof. Jaya, for a very comprehensive talk. I'm glad you talked about older people and non-pharmacological aspect as well. That's very important. Right. So I think as bone health specialists, we are for choices, a lot of choices. But again, at the end of the day, 2/3 of our patients who had hip fracture, as we say, are basically not treated. Yeah. So so let's say if they 2/3 of patients who had hip fracture was discharged from orthopedic clinic and go to KK, Klinik Kesihatan. And one of the Klinik Kesihatan doctor has been attending our talk today and then said, oh, I have to start treatment. So what's your advice? So can they start themselves knowing that they know all the indications and contract indication and everything, or they refer to somebody?
Yeah, I mean, I think that's a very relevant question, Prof. Hakima, because I think definitely our primary care physicians will encounter this. Osteoporosis is, bread and butter, just like diabetes, high blood pressure. So I think everyone needs to know how to manage, at least at a basic level. Some of the guidance that you can use, of course, you can use the Malaysian CPG, which is published by the Malaysian Osteoporosis Society, CPG on management for osteoporosis. That has quite a good, simple guide and algorithm on how you should screen. Basically, although you are dealing with someone who, as you think, most likely is, primary postmenopausal osteoporosis, it's important not to miss secondary causes. So it's important to take a history of, a menopause history, a steroid history, traditional medicine history, or any other thyroid, parathyroid history, and also, if you can, check at least their calcium, phosphate, renal function, and check their vitamin D level if you have access to it. Always supplement them with these agents, because I often tell my patients that these are like batu and cement, calcium and vitamin D. And the contractor is the alendronate or the denosumab, or whatever agent that you give. So I said, if you ada contractor, tak ada batu cement, no point also. And if you have batu cement and no contractor, also you can't build the bone. So, I mean, I think, yes, our primary care physicians can start treating, even alendronate. If you don't have access to denosumab, it's okay. You don't have access to romosozumab, you don't need to go to that end. But at least starting some treatment, even alendronate in someone who has previous hip fracture, can reduce the rate by about 30%, 40% already. So that is something, at least something. So I think you should start treatment. If you think it's more complicated than that, of course, refer them to geriatricians or endocrinologists or rheumatologists, whoever you think is appropriate.
Yeah, thank you, Pujia. Yeah, I think Echo alendronate is quite affordable now. This is like 10 ringgit per month. Yeah.
Yes, it's quite cheap.
If you can hear me well, because one of those.
I can hear you. I can hear.
Well?
Yeah, I can hear you good.
Sorry for the appendix if they can't hear me well. Right. Another thing about vitamin D, Dr. Prof. Jaya. Do you think it's readily accessible? I mean, out of Klang Valley, I'm sure most of university hospitals have access to vitamin D checking. But how about other areas?
Yeah, I mean, I think practically, I mean, we need to strive to try to improve that, because it's important to make sure your vitamin D is replete. As for two reasons. One is, like I said, they are building blocks. I mean, the agents work well if there's vitamin D levels that is satisfactory for bone health. Generally, the US Endocrine Society will say 75 nanomoles per liter. This is for bone health. But having said that, if you really have no access to it, I mean, of course, it can be outsourced to different labs, all the private labs in our country, no matter where you are, which state you are, they can do vitamin D levels, which this is 25 hydroxy vitamin D levels. It can be done everywhere. In some hospitals, of course, in public hospitals, it can be done. Universities, it can be done. But if you don't have access and you really can't do it, and patients also don't want to do it, okay, a safe replacement will be at least 1,000 to 2,000 international units per day. So you need to give at least some replacement. One is, of course, for it to work well. And the other thing is there's also risk of hypocalcemia if you don't correct these vitamin D levels. So if there's hypovitaminosis D, and if you give patients agents like denosumab, which are very potent anti-resorptive, there's a risk of hypocalcemia that can happen after the injection. So to prevent that, at least even if you don't check levels, I mean, of course, you should check levels at least at baseline. And then if it's deficient, you should replace to a level that's more than 75. But if you can't and you haven't, and there's no way of getting it, then at least replace them with a IOM recommendation of like 1,000 to 2,000 units per day. I think that should be a fair way to manage.
Yeah. Thank you. I think the next question would be on ability, as this is like listed on the blog. Not really listed in the blog, but it's like not really accessible to all hospitals. Would you like to share with us about your experience on ability? Is there any patients that having high risk, like for example, uncontrolled diabetes, and suddenly got hip fracture, you got C4, negative 4, as a lot of, uncontrolled diabetes got poor bone quality. So all these high risk patients in terms of CV, if they are not having IAC already, they are at risk. So what are your thoughts on ability on this thing?
Yeah. Okay, so I think that's a good question, Prof. Hakima, because I'm happy to share some of my positive experience. So Evenity or romosozumab, I think we have used in UM for about close to 2 years now, maybe 1.5 years, because initially the company provided us with samples. And I basically used it in the very high risk individuals. I mean, myself, my colleagues, the geriatricians as well, who manage osteoporosis, we have been using it in very high risk individuals. So of course, in these individuals, these are people who had recent fractures, mostly in the last 1 year or 2 years, couple of months. So in the elderly, like you correctly pointed out, often you can't run away from cardiac risks such as diabetes, blood pressure, lipids as well. So what I've tried to do is try to control all of that, as best as I can, while patient is on Evenity or on romosozumab. So far, I've not had any adverse events in terms of MACE or cardiovascular events or cardiac death or anything like that so far, touch wood. But I'm also quite cautious. So if patients had any cardiovascular disease in the past, established stroke or heart attacks or or non-STEMI or anything, I won't touch that patient, Definitely, I won't give that patient Evenity or romosozumab until more data is out. Because I could easily use teriparatide, okay, or Forteo in these patients. But if the patient just has diabetes, high blood pressure, cholesterol, I'll try to control it as best as I can. During the visit, when they come for the injection, I measure their blood pressure just to make sure. I'm being a bit paranoid, but just to make sure that their blood pressure is not super high and they develop a stroke. So I try to control all of that. I tell the patient, sometimes I have had instances, because I probably would have started maybe close to 50 patients on romosozumab so far, maybe around 40 to 50. So I've had instances where I delayed starting it because I wanted blood pressure to be better. So I actually started antihypertensive first, and then asked the patient to come back like 2 weeks later. And then, if it's okay, then start the romosozumab. So I just did it in a very practical, common sense way. I don't think there's any smart I'm not quoting any paper or anything. I don't think, but so far, adding to that the data that people have done some real world study also looking at this. They have done it, I think, in Korea, maybe in Japan as well. I think looking at Evenity or romosozumab in real world. So far, there's no signal with the MACE. It was only seen in the ARCH trial. So that's why FDA still has that warning with Evenity. So like in Singapore, the product insert says that in Singapore, the product insert says basically you cannot use it in people who had past cardiovascular disease, any cardiovascular disease. But in Malaysia, they actually limit it to the last 1 year. So actually, the product insert allows beyond 1 year you can still use. But I have not used it in anyone even beyond 1 year lah. So I try to control risk factors and a bit cautious because I think the data is still quite new.
So that's when experience, and experience in this field plays a role. So when you say that you control the risk factors first, does it mean that you don't give them anything, or you trouble with, let's say, allopregnac?
No, I mean, normally it doesn't take too long, but of course, the patient, if it's very, very high risk, then I will make a choice of giving teriparatide. But if the risk is not very high, normally I won't wait too long, maybe just 2 or 3 weeks before I start. I mean, while I control the other risk factors, then I would start romosozumab.
Okay, let me see if there's any question. Yeah, I think there's no question so far. Right. So to summarize, I think Dr. Jaya has given a very amazing talk and shared his vast experience in the field of osteoporosis and bone health. So basically, in clinic kesihatan or primary care physicians, you're encouraged to start first before, while waiting referral. Let's say if you want to refer to geriatricians or you want to refer to endocrinologist or any bone health specialist, while you are waiting, you can also start first. Knowing that you have to know your risk factors and all the secondary screening, like Dr. Jaya said about your vitamin D level, your thyroid function test level, and everything. Because I have a feeling that our GPs are afraid to start and they refer a lot. Yeah, okay. And then
Yeah, but I think it's quite hard for primary care physicians to actually sort of like refer everyone because it's going to be a big burden. The aging population plus this fracture risk and osteoporosis is going to be bread and butter. I mean, it already is. So I think a basic knowledge in osteoporosis is essential. And I think you cannot, because the patient will not, to wait to see a specialist might take so many months and the patient might fracture within that period.
Exactly, I echo you on that because I'm very happy in a way that as a geriatrician, I receive a lot of referrals from GP saying that I calculated the FRAX score, it happened to be high risk, so I'm referring to you for bone health assessment. Yeah, but the appointment is like 4 months ago. And another GP like referred to me, oh, this patient had hip fracture 2 years ago, and I suppose he needs anti-osteoporotic treatment, so they referred to me. So awareness is there, yeah, but the confidence to start, I think, you can start to build up confidence, start treating patients. When you start treating patients and follow up your patient, you build your confidence from there, and then keep learning. Okay, so, and then Dr. Jaya also talk about vitamin D and calcium supplementation, how important it is in bone health, and also anabolic, yeah, how to use anabolic and risk factors, about when to use anabolic, especially when all other treatments fail already, or it is very high risk patients according to our clinical practice guidelines. Okay. I think with that, I would like to thank Associate Prof. Dr. Jaya for this amazing talk, and then we thank Malaysia Society of Osteoporosis, Malaysia Society and College of Physicians Malaysia for having this special webinar now. Okay, thank you.
Thank you very, very much.
Thank you.